physios, welcome back to our channel. In previous topic we have discussed about chest physiotherapy technique and postural drainage. In this topic we are going to discuss about the mechanical respiration, outline the history of mechanical respiration. In ancient eras, 1500s, Andres Vesalius performed the first documented artificial ventilation using a reed inserted into the trachea of animals. 18th century, the use of bellows for the mouth to trachea ventilation was introduced during resuscitation attempts. In 19th century, 1932, Dr. John Dalziel developed a negative pressure ventilator precursor to the iron lung. Late 1800s, manual methods such as Sylvester and Holger Nielsen technique used for resuscitation. 20th century, 1928, iron lung by Drinker and Shaw introduced during the polio epidemic, and which uses the negative pressure to assist breathing. In 1940s to 1950s, introduction of the positive pressure ventilators for the anesthesia and critical care was introduced. In 1950s, Birdmark 7 ventilator, early IPVV device, was developed. In 1970s to 1980s, volume controlled and pressure controlled ventilators become standard. Late 20th century, introduction of the microprocessor controlled ventilators, 11 modes like SIMV, CPAP, P was introduced. In modern era, advanced ventilators now featuring real-time monitoring, adaptive modes, and non-invasive ventilation options like BiPAP and CPAP was developed, widely used during pandemics like COVID-19, etc. So, when we discuss about, now we are going to discuss about a few definitions and the terms about respiratory ventilator. The term respirator, historically used to describe the mechanical ventilator, especially in older models, now largely replaced by the term ventilator, but may refer to personal protective equipment, that is PPE in other contexts. Lung ventilator is a mechanical device that moves air in and out of the lungs of a patient who is physically unable to breathe or breathing insufficiency. Can deliver controlled or assisted breaths via endotracheal tube or mask. Resuscitator is a manual or mechanical device used to provide emergency ventilation during cardiopulmonary resuscitation. During CPR, this provides emergency ventilation. Example, ambu mask is a self-inflating resuscitator. One of the first positive pressure ventilator developed by Dr. Forrest Bird in 1950s, commonly used in respiratory therapy for IPPV, that is intermittent positive pressure breathing. What is intermittent positive pressure breathing? Intermittent positive pressure breathing is a short-term breathing therapy that delivers positive pressure breaths to expand the lungs, used in atelectasis, patients with weak inspiration and post-operative care. PEEP, that is positive end respiratory expiratory pressure, is a ventilator setting that maintains positive pressure in the lungs at the end of exhalation, prevents alveolar collapse, improves oxygenation, common in ARDS, pulmonary edema, severe pneumonia. CPAP, that is continuous pressure airway, continuous positive airway pressure, delivers a constant level of positive airway pressure throughout the respiratory cycle. Used in obstructive sleep apnea, early respiratory failure, and neonates. Keeps airway open, reduces work of breathing. And also, synchronized intermittent mandatory ventilator is also another type of another term. A ventilator mode where the machine delivers a set number of mandatory breaths. The patient can breathe spontaneously between mandatory breaths and synchronized with their efforts, used in weaning from ventilators. What is PEEP? Repeated as above. The positive pressure, positive end expiratory pressure. Important notice, it was likely repeated. Notice its function is to prevent alveolar collapse and improve oxygenation. Let's have a summary table. IPPV is intermittent positive pressure. It expands the lung and also clears the secretion. PEEP, positive end expiratory pressure, keeps the alveoli open during exhalation. CPAP, continuous positive airway pressure, maintains airway patency. SIM, it is synchronized mandatory ventilator. The purpose is to allow spontaneous breathing with machine support. So let's classify ventilators by third cycling control. Cycling control definition. Cycling refers to the term cycling Cycling controls definition refers to what terminates inspiration and allows expiration to begin. It determines how and when the ventilator switches from the inspiratory to expiratory phase. Okay. Volume cycled ventilator. Cycle ends when a present volume is delivered to the patient. So this cycle ends when the present volume is delivered to the patient. Delivers a fixed tidal volume regardless of the patient effort or lung complications. Lung compliance used in patients who require guaranteed ventilation, example post-OP, neuromuscular condition, etc. Advantages: ensures consistent ventilation. Disadvantage: barotrauma, risk if any resistance is high. Number 2, pressure cycle ventilation. Number 1 is volume cycle ventilator, pressure cycle ventilator. Inspiration ends when the present pressure is reached or delivered to the patient. Volume delivered varies based on a lung compliance and resistance. Used in pediatric and neonatal units to avoid high pressure. Advantages: limit the peak airway pressure, that is, reduce the barotrauma. Disadvantages: variable tidal volume, lesser reliable ventilation. Time to cycle ventilators. Inspiration ends after a present time interval, regardless of pressure or volume. Common in newborn or ICU ventilators with a precise timing control, used in controlled ventilation situations. Advantages: to control over IE ratio. Advantages: require close monitoring to avoid hypoventilation. Flow or mixed cycled ventilators combines multiple cycling methods: pressure, time, flow, volume. Modern ventilators often use the mixed cycling for adaptive support. Example modes are SIMV, PPAP, PRV, pressure support ventilation. Advantages: flexibility and patient ventilator synchrony. Principles of operation of commonly used ventilator. Basic components are power source, electrical or pneumatic. Control system, microprocessor or pneumatic control. Sensories for pressure, flow, volume. Delivery system, circuit, humidifiers, filters. Operating principles: direct the patient efforts in assisting mode. Control inspiratory flow, pressure or volume. Cycle to expiration based on the selected cycling mechanism. Maintain alarms for high or low pressure, volume or disconnection. Now let's discuss about the specific type of ventilators. Number 1, beer ventilator. A volume cycled ventilator. Some modules are pressure cycled. Microprocessor controlled, widely used in ICU surgical settings. Features: allows SIMV, assisted control, and CPAP. Precise control over the tidal volume, PEEP or FiO2. Bennett ventilator includes pressure cycled modes. Example Bennett PR series. Some latter models like Bennett MA1 or volume cycled. Features: originally used for IPPV, intermittent positive pressure, IPPV therapy, adjustable sensitivity and flow, simple mechanical design, ideal for bedside care. Emerson ventilator, negative pressure ventilator, used historically in polio epidemics, encompasses iron lung or tank ventilators. Features: applies a negative pressure around the thorax, draws air into lungs. Now obsolete for but foundational in respiratory care history. And number 4 is bird ventilator, originally developed by Dr. Forrest Bird in 1950s. Models include the Bird Mark 7 and Mark 8, primarily used for IPPB, that is intermittent positive pressure breathing therapy. Features: pressure cycled, pneumatically powered, compact or portable, commonly used in post-OP respiratory therapy, neurological patients. Summary table: ventilator type, cycling method, use case type. Beer ventilator, Bennett ventilator, Emerson and Bird. Beer ventilator is volume cycle, Bennett is volume, either volume or pressure. Emerson is negative pressure, Bird is pressure cycle. So beer ventilator is used in ICU controlled ventilation, advanced type. Bennett is used in IPPB therapy or bedside use, versatile type. Emerson is historical use, polio, obsolete. And Bird is IPPB therapy, portable use, pneumatic. So in next video we'll talk about aerosol therapy, nebulizer and humidification therapy. Hello students, welcome back to our channel. In today's topic we are going to discuss about the aerosol therapy, nebulizer and humidification therapy. In previous video we have discussed about the ventilator types, the terms, definition, the history of ventilation, classification of ventilators and everything. It's just a crisp review, and today we are going to have a crisp overview about the aerosol therapy, nebulizers and humidification therapy. So let's jump into the video. Number 1, principles of aerosol therapy. Definition. Aerosol therapy involves delivering medications or moisture in the form of a fine mist aerosol into the lungs for therapeutic effects, especially in respiratory disorders. Aims: deliver bronchodilators, steroids, or antibiotics directly to the lungs, loosen the mucus for easier expectoration, reduce the airway inflammation, and improve ventilation perfusion ratio. Indications are asthma, COPD, cystic fibrosis, pneumonia, bronchiectasis. The physical properties of aerosol and alveolar depositions are: per particle size. If it's less than 10 μm, deposited in the nose, mouth, pharynx, upper airways. If it's 5 to 10 μm, reaches trachea and larger bronchi. If it's 1 to 5 μm, reaches the lower airway and alveoli, ideal for the therapeutic effect. If it's less than 1 μm, may be exhaled without deposition. Without deposition, it will be exhaled. Particle density and shape. Spherical particles travel better, denser particles settle faster. Sedimentation. Hygroscopicity. Particles absorb moisture, may grow in their sides before reaching alveoli. Next is deposition mechanism. Location affected, principle. If it's inertial impactation, upper airway, pharynx, trachea. The principle: larger particles can't turn with airflow. Sedimentation, small bronchioles or the bronchi. It does gravity pull a medium-sized particle down. Diffusion, Brownian motion, alveoli, random motion, deposition in the very smaller particles. Principles of nebulizer. This is principles of particle properties and aerosol, alveolar and its principle. Next is principles of nebulizer. The purpose is to convert the liquid medication into fine aerosol mist for inhalation therapy. Types and working principle. If it is jet nebulizer, ultrasonic nebulizer, mesh nebulizer. If it's jet nebulizer, uses compressed gas, air or oxygen generate aerosol. Mostly used in it's very low cost. Ultrasonic nebulizer, it's high frequency vibration aerosolized medication. Quieter, more efficient, expensive. Mesh nebulizer pushes liquid through fine mesh to form aerosol, portable and efficient. Key parameters: flow rate 6 to 8 liter per minute for jet nebulizer. Treatment time 5 to 10 minutes. Breathing pattern: slow, deep breaths with inspiratory hold, improves delivery. Principles of humidification therapy. The purpose is to ensure that the inhaled air contains adequate moisture and is not at the body temperature to protect the respiratory tract, especially in patients with artificial airways, tracheostomy, intubation, thick secretions, dry environmental conditions. Physiological norms. Nasal mucosa warms air to it's approximately 37 degrees Celsius and adds humidity to 100%. A relative humidity, that is approximately 44 mm per liter water vapor. By passing the upper airway, that is intubation, leads to humidity deficit, causing mucosal drying, thickened secretions, ciliary dysfunction. Methods to correct the humidity deficits. These are the methods: heated humidifiers, bubble humidifiers, pass-over humidifiers, heat and moisture exchange (HME), aerosol nebulizer. That's it. So these are the 5 methods to correct the humidity deficit. Heated humidifier. So it actively warms and humidifies the gases. Ventilated or tracheostomized patients. Bubble humidifier. Gas in the bubble through water to pick up moisture. Low flow oxygen therapy. Pass over humidifier. Gas passes over a heater water surface. High flow devices. heat and moisture exchange. Passive humidifier that traps exhaled heat or moisture and return it. The uses, it's portable, short-term use. Aerosol nebulizer provide both humidification and also medication delivery. It thicken the secretion and also the bronchial hygiene. So what are the considerations that should be kept in mind before nebulizer or humidifiers or aerosol anything? Temperature regulation is very crucial. Overheating can damage the airway. Use sterilized water to prevent infection. Monitor for condensation in tubing, especially with a heated system. So let's have a summarize of the thing which we have discussed in this entire video. Aerosol therapy, it delivers the fineness to the lungs. Optimal particle size 1 to 5 μm. Aerosol deposition depends on the size, flow, anatomy and breathing pattern. Nebulizers convert the liquid medications into inhalable mist. Humidification therapy prevents drying of airways, essentially in artificial ventilation. Methods of humidification: bubble, heated, pass over, HME, nebulizer based. If you guys have learned something new in this video, stay tuned. Happy learning.